ready. Good afternoon. Welcome to Preventive Medicine Grand Rounds for November 3rd, 2021. I'm Antonio Neri from the Division of Scientific Education and Professional Development. The Preventive Medicine Grand Rounds is sponsored by the CDC Preventive Medicine Residency and Fellowship, as well as the Health Resources and Services Administration Bureau of Health Workforce. The PMRF at CDC provides 12 and 24-month full-time longitudinal service learning opportunities with senior public and population health leaders for physicians, veterinarians, and nurses who have completed the CDC Epidemic Intelligence Service program or have equivalent public health experience. We use Zoom, as you can see, for the audio and presentation, and the question and answer box to pose questions. Note that you can pose questions via the question box at any point during the lecture, and those speakers will answer them at their discretion. Note that your name may be associated with the question you pose. If you do not wish your name to be associated with the question, then please check the Submit Anonymously box on your question. Continuing education credits are available for the live course for up to 1 month after the presentation date, and for the recorded version up to 2 years from the date of presentation through the CDC Training and Continuing Education online portal. The course code to access this Grand Rounds is all capital letters CDC PMRF. Again, all capitals CDC PMRF. If you have questions, please contact myself, Antonio Neri, or email the program at prevmed@cdc.gov. Please remember that the views presented by the speaker are theirs alone and do not represent CDC, the Department of Health and Human Services, or the US government. Before we start our Grand Rounds, we'll take our usual moment of silence for our friends, family, and colleagues who have suffered from COVID or even passed away. Okay. Today's Grand Rounds will be entitled Introduction to Tribal Public Health Infrastructure and CDC by Captain Karen Hearod, Captain Karen Hearod, who is with the Centers for Disease Control, Center for State, Local, Tribal, and Territorial Support. Captain Hearod, the floor is yours. Take it away.
Good afternoon, and thank you for allowing me the time to share with you this presentation about tribal public health infrastructure and CDC. So as was shared, I am Captain Karen Hearod, and I'm a citizen of the Choctaw Nation of Oklahoma, and I'm coming to you today from the Choctaw Reservation in Oklahoma. Next slide, please. The learning objectives for today's presentation include develop more awareness and knowledge of the diversity of American Indian Alaska Native populations, identify historical laws that greatly impact American Indian Alaska Native populations, understand how AIAN populations are unique to public health, develop awareness of partners that contribute to AIAN public health, understand how CDC supports tribal public health infrastructure, and learn about CDC, Office of Tribal Affairs and Strategic Alliances, and their collaborations and work with American Indian Alaska Native populations. Next slide, please. So as an introduction for my office, the Office of Tribal Affairs and Strategic Alliances, or OTASA, we reside within CDC's Center for State, Tribal, Local, and Territorial Support, or CSTLTS. CSTLTS works to improve community health outcomes by strengthening state, tribal, local, and territorial health agencies. Next slide, please. This organizational chart highlights CSTLTS leadership. In the middle of the chart, you see our director, Dr. Jose Montero, and the acting deputy director, Dr. Andrea Young. You also see the OTASA office that I direct depicted on the left. Next slide, please. OTASA's mission is to affirm the government-to-government relationship between CDC and American Indian and Alaska Native tribal nations by advancing connections, providing expertise, and increasing resources to improve tribal communities' public health. Next slide, please. OTASA works closely with American Indian Alaska Native communities to coordinate activities, provide expertise, technical assistance, and resources. As CDC's principal point of contact for American Indian Alaska Native tribal nations and tribal serving organizations, OTASA works to connect tribal nations, tribal serving organizations, and other stakeholders to CDC and the Agency for Toxic Substances Disease Registry, or ATSDR programs. We ensure that American Indian Alaska Native communities receive public health services that keep them safe and healthy, and we provide and facilitate funding for building and improving cross-cutting tribal public health infrastructure. Next slide, please. Before we discuss public health infrastructure, it's important to first note the vast diversity of American Indian Alaska Native communities. There are currently 574 federally recognized tribal nations across the United States. Each tribal nation is unique in their history, cultural practices, and traditions. Moreover, tribal nations range in capacity of public health workforce, as well as the tribal public health departments and population size of the tribal nations themselves. Tribal nations can range in size from some California rancherias of less than 1 acre to the Navajo Nation at more than 17 million acres. Tribal sovereignty refers to the rights of American Indian and Alaska Natives to govern themselves. Each tribal nation also differs in their own laws and policies. As sovereign nations, the federal government has a government-to-government relationship with each tribal nation to uphold. Next slide, please. When understanding public health infrastructure for American Indian Alaska Native populations, it is important to first understand a few key historical federal Indian laws that greatly impact tribal nations and American Indian Alaska Native populations. Next slide, please. We will start with the Federal Indian Removal Act of 1830. This federal policy authorized President Jackson the right to make land exchanges by forcibly removing the 5 tribes, Cherokee, Muskogee Creek, Chickasaw, My Tribe, Choctaw, and Seminole from their ancestral lands against their will. Over the next several decades, more than 40 tribes were removed to Indian Country, an area that now comprises the state of Oklahoma. President Jackson rationalized the removal program as a benevolent effort that gave American Indians one last chance to assimilate and give up their culture. In President Andrew Jackson's address to Congress, he told lawmakers, "Surrounded by our settlements, these Indians have neither the intelligence, the industry, the moral habits, nor the desire of improvement which are essential to any favorable change in their condition. Established in the midst of another and superior race, and without appreciating the causes of their inferiority or seeking to control them, they must necessarily yield to the force of circumstances and ere long disappear." The Treaty of Dancing Rabbit Creek, which was proclaimed on February 24, 1831, between the Choctaw and the United States, is the treaty that brought my family to Oklahoma, where I live today. About 17,000 Choctaws started the journey from Mississippi to Oklahoma, and it's estimated that nearly a third died along the way from starvation, exposure, and disease. Today, though, we claim over 200,000 Choctaw Nation citizens. I wanted to just take a chance and share briefly a personal experience that I have related to the removal route and the journey. So in June of 2012, I had the honor of participating with a small group from the University of Washington's Indigenous Wellness Research Institute and the Choctaw Nation of Oklahoma, rewalking the historical Trail of Tears. The project was named Jopley, and in the Choctaw language, Jopley means to walk slowly and softly. The goal of the walk as a pilot project was to connect culturally with the space, to discuss and pledge to the health of future Choctaw generations. We began and ended the day with cultural teachings and really reflected on our diet and exercise. Prior to this walk, I had gained some weight and wasn't in great shape, so I was getting kind of in touch with my physical health. It also presented an opportunity for participants to make meaningful health changes in our own lives. So the removal route is about 500 miles. And so as we planned, for the walk, we had to do a lot of research around the history of the trails. And that meant that we learned some about our own family's path to Oklahoma. And I just wanted to share an experience that I had personally during this time. There was a part in the path that's close to present day Washington State Park, and that's a recreated kind of historical site in Arkansas of a town that was there previously. And my family had come through this area, and for those of you that aren't familiar with Arkansas, there's several areas that can become very boggy and hard to get through. And my family had come upon this site and had to wade through water that was kind of up to our shoulders. And a lot of people became sickened during this time, and even some of the little ones died across this. And so when they came out of this area, there was a little town, and this town would not allow them to stay. And so they had to keep walking in a town close to present day Washington State Park, allowed them to stay and fed them and gave them comfort. And when we rewalked the walk at this time, I became pretty overwhelmed putting my feet in the soil kind of my ancestors. And we were all, very tired and worn down at this point in time. And some archaeologists that were staying at Washington State Park, when we walked through, invited us to stay the night and fed us a meal and gave us comfort during this time. And it really brought home to me that the meaning of this trail and the sacrifice that our ancestors made for us to keep our tribal sovereignty and make a new home in Oklahoma. So I just wanted to share that, because I think these stories kind of bring them that, make these experiences more real and bring deeper understanding. Let's go ahead and go to the next slide, please. So in 1851, the US Congress passes the Indian Appropriations Act, creating the reservation system to move Western tribes onto reservations. The men who created the reservation system believed that American Indians could be confined to one particular geographical place reserved for them. They could become civilized and assimilated into American life and transformed into good Christian farmers. The reservations were established to make sure the remaining tribes converted to Christianity and became Americanized. Within reservation borders, American Indians were not allowed to leave except by permission. Those who left were arrested and severely punished. The federal policies were enforced by Indian agents, which suppressed tribal culture and traditional activities. Treaties were the primary method for creating reservations, but Congress suspended formal treaty development in 1871. Therefore, executive orders, congressional acts, or any legal combination recognized by the federal government were used to establish federal reservations. Go ahead and go to the next slide, please. The General Allotment Act of 1887 is also known as the Dawes Act of 1887. This policy had a disastrous effect on many tribes. This federal policy was designed to de-tribalize the American Indian by destroying the idea of communal land ownership on the reservations. The provisions of the General Allotment Act include the allotments were held in trust by the U.S. government for 25 years. Eligible American Indians had 4 years to select their land, but afterwards the selection would be made for them by the Secretary of the Interior. U.S. citizenship would be conferred upon American Indians who abandoned their tribes and adopted the habits of quotation civilized life. And lastly, all land not allotted reverted to the control of the federal government and can be sold. Consequently, land owned by American Indians decreased from 138 million acres in 1887 to only 48 million acres in 1934. This act also established the Dawes Roll, which my tribe, the Choctaw Nation, still uses for descendancy and tribal membership. My great-great-grandmother, Matilda Hearod, and her son, my great-grandfather, James Hearod, were the original enrollees for my family. Go ahead and go to the next slide, please. The Indian Reorganization Act of 1934, also known as the Wheeler-Howard Act, was signed by President Roosevelt on June 18, 1934. This law allows tribes to establish formal governments within limited powers and allows the formation of corporations to manage tribal resources. So the Indian Reorganization Act offered federal subsidies to tribes that adopted constitutions like that of the United States and replaced their government with city council style governments. Also, American Indians were given the right to establish a credit system, and it granted certain rights of home rule to American Indians. Provided some vocational education. Also, employment of American Indian in the Bureau of Indian Affairs was also increased. This act served to give American Indians a chance at a New Deal, quotation marks, that ran parallel to many other programs. Go ahead and go to the next slide, please. In 1953, Congress passes a resolution beginning federal policy of termination. The image above shows a relocation brochure distributed to American Indians in the 1950s. A companion policy of relocation moves Indians off reservations and into urban areas. Through these policies, the BIA planned to move thousands of American Indian people to cities and urban jobs. The goal really was to absorb American Indians into mainstream society. Go ahead and go to the next slide, please. So from some of the key federal Indian laws that we've just discussed, I would like to now transition in to discuss social determinants of health and how American Indian Alaska Native populations might uniquely experience social determinants of health. Go to the next slide, please. Historical trauma is the intergenerational collective experience of complex trauma that was inflicted on a group of people who share a specific group identity or affiliation, such as nationality, religious affiliation, or ethnicity. As discussed earlier, the forced removal from native lands because of government policy is one example of historical trauma. Another example experienced widely across American Indian and Alaska Native population is government policy sending children to boarding schools, which prohibited speaking Native languages or practicing their individual spirituality. These policies have caused tremendous impact across multiple generations, such as loss of Native languages, cultural practices, and loss of Native foods as a result of loss of land. On November 26, 2019, the President signed Executive Order 13898, forming the Task Force on Missing and Murdered American Indian and Alaska Natives. also recognized as Operation Lady Justice. The OLJ Task Force aims to enhance the criminal justice system and address the legitimate concerns of American Indian and Alaska Native communities regarding missing and murdered people, specifically missing and murdered Indigenous women and girls. So this task force is a multi-agency effort that will allow top federal officials to engage, coordinate, and work with tribal governments on developing strategies to address the crisis by looking at means to collect and manage data across jurisdictions, establish protocols for new and unsolved cases, establishing multi-jurisdictional cold case teams, improving response to investigative challenges, and providing clarity on roles, authorities, and jurisdiction. For CDC, Laura Collar and Dr. Delight Satter represent CDC on this OLJ task force. Additionally, as we look at social determinants of health, we see that multi-generational housing is an important consideration when developing strategies for public health programs. Many American and Alaska Native populations reside within multiple generations with youth and elders in the same home. So this has really come to light when we look at addressing quarantining related to COVID-19 and specific strategies to protect the elders in the home. Access is another important consideration for Native populations. Access to food and healthcare can be difficult due to geographical location alone for some. In wintertime especially, some roads can be inaccessible or at times of flooding. Also, specifically for healthcare access, the rurality of American and Alaska Native communities can cause a provider shortage. Additionally, compared to white residents, rural AIAN populations were disproportionately concentrated in rural counties that are above the median for a proportion of their population that lacks health insurance. Additionally, food insecurity is strongly correlated with malnutrition and underweight, as well as obesity and type 2 diabetes. Sometimes access to vegetables and fruit intake can decline significantly as food insecurity increases, which can contribute to excess cancer and cardiovascular risk. Go ahead and go to the next slide, please. So the American Indian and Alaska Native people have long experienced lower health status when compared with other Americans. Lower life expectancy and the disproportionate disease burdens exist perhaps because of inadequate education, disproportionate poverty, discrimination in the delivery of health services, and cultural differences. These are broad quality of life issues rooted in economic adversity and poor social conditions. American Indians and Alaska Natives born today have a life expectancy that is 5.5 years less than the US all races population. The specific reasons for health disparities are complex and represent much more than who American Indian and Alaska Natives are. They also represent where people live and the services available and accessible to them. Factors such as having a regular source of care, language and communication barriers, lack of diversity in the healthcare workforce, high rates of poverty, lack of insurance coverage, discrimination, and large distances from healthcare services have all added to the disparities. Go ahead and go to the next slide, please. It is important to note that although the trauma history that I've shared is a part of the story, it is just that, a part of the story. Our history is also a history of vast cultural knowledge, wisdom, ceremony and practices, resilience, and survival. Additionally, some tribal nations are defining their own social determinants of health, including factors such as cultural identity, family, participation in cultural activities, access to native lands, and natural resources. With this in mind, it is important to consider specific cultural strategies to address public health prevention for American Indian and Alaska Native populations as a result of the previously mentioned unique social determinants of health and health disparities. So I want to highlight tribal practices for wellness in Indian country, which will be discussed in more detail later in the presentation, as a key example that supports tribal practices as a path to prevention and wellness promotion in American Indian Alaska Native communities. A TPWIC is a 4-year cooperative agreement. American Indian and Alaska Native tribes and Alaska Native villages or tribally designated organizations that work with tribes. There's 15 urban Indian organizations receiving a total of approximately $5 million per year. So the mission of TPWIC is to encourage and support tribal practices that build resiliency and connections to community, family, and culture. 7 strategies are employed toward this mission. Connect cultural teachings to health and wellness, support seasonal cultural practices that support health and wellness, implement social and cultural activities that promote community wellness, establish and maintain collaborations that strengthen well-being, support intergenerational learning for well-being and resilience, promote traditional healthy foods, and promote traditional and contemporary physical activities. It's important to note in addressing public health for American Indian and Alaska Native population, it's important to build flexibility into the cooperative agreement or program to allow American Indian and Alaska Native populations to bring cultural and traditional adaptations that work individually for their community. Flexibility per tribal nation is important, as not one tribal nation is the same, and their experiences are all different, and their traditions and cultural are all unique to them. Next slide, please. So shifting to looking at public health infrastructure and important partners in Indian country. So public health infrastructure provides communities, states, and the nation with the capacity to prevent disease, promote health, and prepare for and respond to acute threats and challenges to health. Infrastructure is the foundation for planning, delivering, evaluating, and improving public health, and enables the public health system to function, including a workforce, training in public health core competencies, information and data systems for rapidly assessing and communicating information, and the ability to respond to public health needs in culturally responsive and relevant ways. Some tribes look at public health more like community health, where it's an extension to healthcare services. So in this section, we will go into more detail of tribal public health infrastructure and how CDC works with tribal nations and their public health infrastructure. This section will also discuss tribal partners in more detail. Next slide, please. So I wanted to just share briefly the differences between Title I and Title V, also known as 638. So when we look at Title I tribally contracted facilities, they are run by federally recognized tribes or organizations with the IHS to plan, conduct, and administer one or more individual programs, functions, services, or activities, or portions thereof that IHS would otherwise provide for Indians because of their status as American Indian Alaska Natives. For Title V tribally compacted facilities, they're run by federally recognized tribes or tribal organizations with the IHS to assume full funding and control over programs, services, functions, or activities, or portions thereof that IHS would otherwise provide. So my tribe, the Choctaw Nation of Oklahoma, is a 638. So they have elected to run the full array of services for the Choctaw Nation. Go ahead and go to the next slide, please. So both Title V and Title I for tribal administration of programs formerly administered by IHS, the major difference is a matter of oversight. So under Title V, a tribe may redesign or consolidate programs, services, functions, or activities, also known as PFSFAs, because we in the government love our acronyms, and reallocate or redirect funding without IHS approval in accordance with the Indian Self-Determination Education Act. In contrast, IHS must approve any substantial changes to a Title I contract. The programs are not exclusive because tribes can choose which PSFAs or portions to assume. A tribe may combine Title V, Title I, and direct services to best meet the needs of its communities. And Tribal 638 programs are eligible for federally qualified health center grants at FQHC. Go ahead and go to the next slide, please. So urban Indians not only share the same health problems as the general American Indian and Alaska Native population, but their problems may be exacerbated in terms of mental and physical hardships because of the lack of family and traditional cultural environments. It is important to understand the different partners that contribute to urban Indian health, as approximately 70% of American Indians and Alaska Natives live in urban areas. Go ahead and go to the next slide, please. Urban Indian health centers. So these are designated federally qualified health centers that provide comprehensive primary care and related services to American Indians and Alaska Natives. The facilities are owned or leased by urban Indian organizations and receive grant and contract funding through Title V of the Indian Healthcare Improvement Act. This is a picture of the Missoula Urban Indian Health Center in Missoula, Montana. Go ahead and go to the next slide, please. The IHS provides contracts and grants to 41 urban-centered nonprofit urban Indian organizations providing healthcare services at 59 locations throughout the United States. The 41 programs engage in a variety of culturally appropriate activities to increase access to health services for urban Indians. The National Council of Urban Indian Health, or NACUI, is a national nonprofit devoted to the support and development of quality, accessible, and culturally competent health services for American Indians and Alaska Natives living in urban settings. Next slide, please. So before we move on to Indian health boards and tribal epicenters, we have a question in the box. Does OTASA have resources on which tribes are Title I versus Title V? Similarly, are these resources on which tribes use BIA police officers compared to tribal police departments? So this is a complicated question when you are looking at BIA and police officers and how tribal police departments function. So I would need a little bit more time to unpack that one, but we do have some resources that we could point you to as far as Title I versus Title V. And I will share an email at the end of the presentation. If you want to reach out to us, I would be so happy to talk with you about that offline. So let's go to the Indian health boards and tribal epicenters. So these partners work with tribal nations and urban Indian health organizations to support and fill in gaps in healthcare programs and essential public health services. Go ahead and go to the next slide, please. Area Indian health boards are nonprofit tribal advisory organizations run and organized by participating tribes. Most focused on 4 areas as they pertain to the health of American Indian Alaska Native people: health promotion and disease prevention, legislative and policy analysis, training and technical assistance, and surveillance and research. You see on this slide that there's 12 regional tribally designated organizations run and organized by participating tribal nations. So we have the Alaska Native Health Board for the Alaska area. And these also are connected to the 12 areas for Indian Health Service. So as you may or may not be aware, HHS has 10 regions, but Indian Health Service has 12 areas. So we have the Alaska Native Health Board, the Albuquerque Area Indian Health Board, the Great Lakes Area Tribal Health Board, Rocky Mountain Tribal Leaders Council, California Rural Indian Health Board, Great Plains Tribal Chairman's Health Board, Northwest Portland Area Health Board, Intertribal Council of Arizona, the Southern Plains Tribal Health Board, the Navajo Nation Department of Health, and the United South and Eastern Tribes. And this picture depicts the Indian Health Board of Minneapolis. Go ahead and go to the next slide, please. Additionally, the National Indian Health Board, or NIHB, is a nonprofit organization that represents tribal governments, both those that operate their own healthcare delivery systems through contracting and compacting, and those receiving healthcare directly from IHS. The area health boards serve as member organizations of the National Indian Health Board and the communication link between the NIHB and tribes. Member organizations advise in the development of positions on health policy, planning, and program design. They gather information and review public opinion and proposals. In areas without an area health board, the NIHB representative communicates policy information and concerns to the tribes in that area. Go ahead and go to the next slide, please. Additionally, Tribal Epidemiology Center, or TECS, are Indian Health Service division-funded organizations who serve American Indian, Alaska Native, tribal, and urban communities by managing public health information systems, investigating diseases of concern, managing disease prevention and control programs, and responding to public health emergencies and coordinating these activities with other public health authorities. Each TEC is unique in terms of the types and range of activities conducted and services offered. There are 12 TECs in total with different missions and activities per their area. Go ahead and go to the next slide, please. So in this next subsection, we'll provide details on federal agencies and how they partner with tribal nations, including a few highlights of projects supporting public health infrastructure in Indian country. Most federal work with American Indian, Alaska Native tribal nations and urban American AIAN individuals flows from two federal departments, Department of the Interior and Department of Health and Human Services. Go ahead and go to the next slide, please. Key federal partners working with tribal nations include the Department of Interior. The BIA is the oldest agency of the U.S. Department of Interior. The BIA carries out its core mission to serve the federally recognized tribes through 4 offices. The Office of Indian Services, that office operates BIA's general assistance, disaster relief, Indian child welfare, tribal government, Indian self-determination, and reservation roads programs. When I first started my career, I'm a licensed clinical social worker by training. I started out at a small clinic in Wewoka, Oklahoma, and I worked closely with this office related to general assistance and Indian child welfare. The Office of Justice Services directly operates or funds law enforcement, tribal courts, detention facilities, or on federal Indian lands. The Office of Trust Services works with tribes and individual American Indian and Alaska Natives in the management of their trust land, assets, and resources. And finally, the Office of Field Operations oversees 12 regional offices and 83 agencies, which carry out the mission of the Bureau at the tribal level. We also have the Bureau of Indian Education. It provides education services from early childhood through life in accordance with the tribe's needs for cultural and economic well-being. Within the Department of Health and Human Services, the public health service agencies include Indian Health Service, and IHS is responsible for providing federal healthcare services to American Indians and Alaska Natives. IHS, as I shared before, has 12 area offices and 170 IHS and tribally managed service units. The Food and Drug Administration ensures that food is safe and pure and wholesome. The Health Resources and Services Administration provides healthcare to people who are geographically isolated, economically, medically vulnerable. The National Institutes of Health supports biomedical and behavioral research. And the Substance Abuse and Mental Health Services Administration improves access and reduces barriers to high quality, effective programs and services for individuals who may suffer or at risk of addictive and mental health disorders. And of course, the Centers for Disease Control and Prevention. Go ahead and go to the next slide, please. So I wanted to shift gears just a little bit and share with you the Tribal Behavioral Health Agenda. So an example, this is an example really of how agencies are collaborating with tribes. So the Substance Abuse and Mental Health Services Administration, or SAMHSA, and Indian Health Service worked with the National Indian Health Board to gather input from tribal leaders and other relevant partners to develop the National Tribal Behavioral Health Agenda. So the TBHA, it's not a strategic plan. It's rather a guiding blueprint that will assist in strengthening policies and programs, aligning disparate resources and facilitating collaboration. It identifies existing strategic plans and efforts that can serve as initial pathways for action and as a single unifying tool, which engage partners can gather utilizing common language and priorities. And I know several tribal citizens that worked on this tribal behavioral health agenda, and it was really a labor of love for them. It addresses 5 foundational elements: historical and intergenerational trauma, national awareness and visibility, social ecological approaches, prevention and recovery supports, and behavioral health services and systems improvement. It really works to provide a clear national statement about the extent of behavioral health related problems and their impact on the well-being of tribal communities. It identifies the foundational elements that I shared. It also provides actions that tribal, federal, state, and local governments and the private sector should consider based on evidence and practice-based strategies. It elevates priorities for actions that could or are likely to contribute to meaningful progress in tackling persistent behavioral health problems for Native youth families and communities. And it guides the development of strategies that over time more cohesively address factors that contribute to improved emotional health. And there's a link here to the Tribal Behavioral Health Agenda if you have interest in reading it more fully. Next slide, please. So I have a question that says, might you be aware or know the status of the Office of Minority Health's initiative to create a Center for Indigenous Innovation and Health Equity Center? Yes, I am aware of this. I attended a listening session last week about the creation of the center. On the Office of Minority Health website, there should be slides from that listening session that can give you more information if you have interest. I know they are also recruiting elected tribal leaders to serve on their newly formed Tribal Advisory Committee. So they are asking for help to publicize that as well. And reference the recording of this webinar, I am not sure I know it's being recorded and we can address that at the end of the session. So as we shift gears, the CDC has several projects related to tribal public health infrastructure. I wanted to talk about these projects now that I've explained and discussed historical factors and components of health in tribal communities. I'm going to highlight a few of these projects supporting public health infrastructure. Please understand that in this limited time, this is not an exhaustive list of projects supporting tribal public health infrastructure, just trying to give a few highlights. Go ahead and go to the next slide, please. Direct funding of American Indian Alaska Native tribes and organizations. Direct funding allows tribal nations to compete with agencies of similar infrastructure. States get direct funding for many public health issues, and tribal nations must rely on states to pass funding down through them. Moreover, funding that is specific for tribal nations would also allow more flexibility to account for cultural and traditional best practices. CDC ATSDR currently has multiple direct funding opportunities to tribal nations and tribally designated organizations that help support public health efforts and support capacity building in Indian country. Listed on this slide are some examples of fundings to tribes and tribal organizations. I'll talk a bit more about each of these funding mechanisms throughout this section. Go ahead and go to the next slide, please. I mentioned the tribal epicenters a little bit earlier in the presentation. The Tribal Epidemiology Center Public Health Infrastructure, or TECFI, is a CDC cooperative agreement that complements Indian Health Service funding to increase the TEC's public health capacity and infrastructure. The purpose of TECFI is to reduce programmatic silos within TECs within the TECs and expand their ability to perform the 7 core functions by building data infrastructure, increasing staff capacity, and establishing partnerships. CDC supports the 12 TECs and 1 network coordinating center. The Network Coordinating Center coordinates the evaluation of this initiative and provides project organization, logistics, and communications across the TECs. TECFI is a 5-year cooperative agreement, and the TECs receive a total of approximately $8.5 million per year. Although each of the TECs projects are unique, they're all engaging in the following 3 key strategies to contribute to overall health for American Indian Alaska Native people nationwide: strengthening public health capacity and infrastructure, implementing activities to improve effectiveness of health promotion and disease prevention, engaging in sustainable activities after the funding cycle ends. The program intends to reduce chronic diseases and risk factors, reduce disparities in health outcomes, and improve overall health by building public health capacity and infrastructure in Indian country for disease surveillance, epidemiology, prevention, and control of disease, injury, or disability. And you see on this slide where all of the TECs are located, and they are within the 12 Indian Health Service areas. Go ahead and go to the next slide, please. Tribal Practices for Wellness in Indian Country is a 4-year cooperative agreement. American Indian, Alaska tribes, and Alaska Native villages are tribally designated organizations that work with tribes, and 15 urban Indian organizations receive a total of approximately $5 million per year. TPWIC encourages and supports tribal practices that build resiliency and connections to community, family, and culture. Over time, these can reduce risk factors for chronic disease and promote wellness among American Indian Alaska Natives. The CDC funds 36 tribes and urban Indian health centers through TPWIC. The TPWIC strategies fall into the following 3 general areas: health promotion, increase traditional physical activity, traditional foods, and overall healthy living practices; cultural practices, increase knowledge and sharing of tribal history and cultural practices; social and emotional well-being, an increased sense of belonging to tribe, sense of connection to culture, and intergenerational interactions are having a positive impact on well-being. And this slide represents the states where the recipients are located. And as you see, we have recipients at several places on the map. Go ahead and go to the next slide, please. I'd now like to talk about good health and wellness in Indian country. Good health and wellness in Indian country continues to support healthy behaviors for American Indian, Alaska Natives, and emphasizes strategies to reduce risk factors in Native communities to attain long-term goals by supporting a coordinated and holistic approach to healthy living and chronic disease prevention. Work also is going toward reinforcing the work already underway in Indian country to make healthy choices easier for American Indians and Alaska Natives. Continuing to support culturally appropriate, effective public health approaches, and working with more tribes and extending the program's reach and impact through tribal organizations, including urban Indian organizations. Long-term goals include reducing type 2 diabetes, reducing commercial tobacco use, reducing high blood pressure and high blood cholesterol, increasing the intake of healthy foods and physical activity, and also increasing breastfeeding. Go ahead and go to the next slide, please. I'd now like to share a little bit about the Tribal Public Health Capacity Building and Quality Improvement Umbrella Cooperative Grant, also known as OT 18-1803. This program's purpose is to provide resources for American Indian and Alaska Native tribal nations and regional American Indian Alaska Native tribally designated organizations to optimize the quality and performance of the tribal public health system, including infrastructure, workforce data, and information systems, programs and services, resources and communication, and also partnerships. Work in these areas will increase the capacity of Indian country to identify, respond to, and mitigate public health threats and decrease burden of disease among American Indian Alaska Natives. This cooperative agreement is in its 4th year of funding. OT 18-1803 strategic areas and proposed activities work toward addressing 8 of the 10 essential public health services. Tribal public health system infrastructure encompassing developing policies, workforce, assuring a competent workforce, tribal public health partnership encompassing mobilizing community partnerships, tribal public health programs and services linking to care and investigations, tribal public health resources and communication encompasses informing, educating, and empowering, and tribal data and information systems, evaluating and monitoring health. Go ahead and go to the next slide, please. And on this slide, you see our OT 18-1803 recipients. This cooperative agreement awards 25 federally recognized American Indian Alaska Native tribal nations and regionally tribally designated organizations. So 14 tribal nations and 11 regional tribal organizations. Go ahead and go to the next slide, please. And here is a map showing the recipients. Wisconsin, Oklahoma, and Washington State have the most representation. Go ahead and go to the next slide, please. So this slide just shares the funding strategies under OT 18-1803, funding strategy 1 and funding strategy 2. This cooperative agreement is an umbrella cooperative agreement allowing CDC CIOs to provide additional project plans to support public health infrastructure through the second funding strategy. The funding strategy is the base funding providing $22,000 to each recipient for public health infrastructure under the 6 strategies mentioned previously. Recipients receiving the base funding are then eligible for funding strategy 2 projects, allowing for less competition for direct funding. Funding strategy 2 was created to maximize CDC programs priorities and health system needs in Indian country. The funding provides recipients opportunities for substantial topic-specific funding. There are currently 6 CIOs that have projects funded under strategy 2. Go ahead and go to the next slide, please. So I'd like to share with you now some project examples of OT 1803. The Forest County Potawatomi community have an agreement for expanding tribal members' access to health and wellness resources, increasing engagement in community events, and supporting the involvement of tribal members and prioritizing and addressing the community's public health needs. FCPC was able to improve their data and knowledge of their community health by conducting needs assessments while also improving the recipients' outreach to their community. FCPC has enrolled tribal members and their family affiliates in the Manage Well Health System and has been better able to understand the health and concerns of the community through biometric screenings and health assessments as part of their enrollment. I'm going to pause here and plug in my headphones. Stand by. My headphones said they have had too much talking, so thank you for that. So the Rocky Mountain Tribal Leaders Council is supporting a public health workforce expansion in Indian Country project modeled after CDC's Public Health Associate Program. They partnered with 7 tribal colleges where students are selected and complete quick impact projects centered around behavioral health. This initiative to improve the public health workforce for American Indian and Alaska Natives also successfully developed another position within the recipient's organization to initiate partnership development amongst colleges. This position has been able to be sustainable by the recipient for a long-term partnership involvement. And lastly, the public health accreditation standards. This has multiple recipients. Multiple 1803 recipients are addressing public health accreditation standards. Standards include development and implementation of communication plans, community health assessments, strategic planning, community health improvement plans, and continuity of operation plans, as well as data improvement, among others. So Chickasaw Nation has been able to complete the big 3. The community health assessment and also the community health improvement plan and strategic plan, and is preparing to officially apply for PHAB accreditation. Cherokee Nation is working towards reaccreditation, and the Gila River Eastern Band of Cherokee Indians, Choctaw Nation, Ho Chunk Nation, Lumi Nation, Wabanaki Health and Wellness, and White Earth Band of Chippewa Indians are all progressing in PHAB standards. Go ahead and go to the next slide, please. There we go. So through the 1803 Cooperative Agreement, CDC provides almost $60 million through supplements to an existing CDC Cooperative Agreement, Tribal Public Health Capacity Building and Quality Improvement. This includes about $39 million to 12 regional tribal organizations to serve 10 HHS regions and 4 tribal nations, serving populations of 40,000 or more to prevent, prepare for, and respond to COVID-19. And $12 million to 11 regional American Indian and Alaska Native tribally designated organizations to build public health capacity during the COVID-19 response and recovery. The OT 1803 Cooperative Agreement acted as an already existing funding mechanism to rapidly provide COVID-19 supplemental funding to regional organizations in response to the pandemic. The CDC ATSDR Tribal Advisor Committee, that will be discussed in more detail later, has requested continued funding and expansion of recipients for this cooperative agreement. A new umbrella NOFO is expected in 2023. Go ahead and go to the next slide, please. The Supporting Tribal Public Health Capacity in Coronavirus Preparedness and Response Grant, or OT20 2004. In addition to the already existing funding mechanism, OT 1803, CDC developed a new grant to provide COVID-19 funding direct to tribal nations and organizations. This is a non-competitive grant that provides funding to 346 tribal recipients. This includes 290 tribal nations, 25 tribal consortia, and 31 tribal organizations, which reach more than 490 tribes and more than 39 million individuals, according to grantee self-report. Go ahead and go to the next slide, please. Additionally, the Strengthening Public Health Systems and Services through National Partnerships to Improve and Protect the Nation's Health Cooperative Agreement, or OT 1802. So the purpose of this initiative is to strengthen the nation's public health infrastructure, ensure a competent, current, and connected public health system, and improve the delivery of 10 essential public health services through capacity building assistance. The program strategies include strengthening the capacities of public health systems infrastructure, leadership and workforce, data and information systems, communication and information technology, partnerships, law and policies, and programs and services. Partners will deliver capacity building assistance through technical assistance, training, information, sharing, technology transfer, materials development, or funding that enables organizations to serve customers better and operate in a comprehensive, responsive, and effective manner. Organizations working on tribal-related projects who received awards through this cooperative agreement include, but are not limited to, the National Council of Urban Indian Health, NACUI, the National Indian Health Board, NIHB, and the National Network of Public Health Institutes. Next slide, please. I want to shift just a minute and talk about working with tribal nations training. This training was created by NIHB with funding and support from the Center for Disease Control and Prevention, CDC. The Working with Tribes training course is part of NIHB's aim to increase familiarity with tribes throughout all levels of government, elevate tribal healthcare and public health needs, and improve non-tribal government employees' familiarity and comfort with working with tribes. The training module was created using input from area Indian health boards and other tribal partners, CDC staff and other federal staff, and non-tribal stakeholders. The training underwent 2 rounds of pilot testing and review prior to the public release. It may also be useful for other professionals, such as those who are working with tribal leaders or conducting consultation activities. Additionally, the first module of the course provides general information on the impacts of colonization and historical trauma on tribal nations. That may be more widely useful for those who want to learn more about the experience of this nation's indigenous peoples. You can access this training if you have interest on the NIHB's website. Go ahead and go to the next slide, please. Racial misclassification of American Indian and Alaska Native people endangers lives. It marginalizes American Indian and Alaska Native people and leaves the organizations that serve them without sufficient data to make decisions or fund the services they provide. This report examines the problem of racial misclassification on death certificates with a particular focus on the role of funeral directors in urban communities. For over a year, the National Council of Urban Indian Health investigated possible factors that might create racial misclassification and look for solutions to prevent these factors. This document is intended as a broad and introductory guide for a variety of stakeholders that can help prevent this problem, including funeral directors, businesses and industry associations, statisticians and public health experts, and policy stakeholders. The report consists of 5 parts: a review of the vital record systems, racial misclassification of deaths, and regional relevant literature on this topic, a description of the survey, listening sessions, and interviews conducted by NACUI to learn about funeral director policies, practices, and experiences, results from these activities, and then a discussion summarizing what NACUI has learned, and a list of recommendations geared at the prevention of racial misclassifications on death certificates before it occurs. Go ahead and go to the next slide, please. The Public Health in Indian Country Capacity Scan, or FIX. The National Indian Health Board, in partnership with the Centers for Disease Control and Prevention, released the 2019 Public Health in Indian Country Capacity Scan that provides a comprehensive picture of tribal public health infrastructure and activities, specifically immunization, screening, and prevention education activities that are widely occurring in Indian Country. This report describes the current state of public health services from a national perspective throughout tribal communities. The 2019 FIX report serves as a valuable tool for Indian Country to identify needs and strengths in tribal public health, to measure progress over time, to allocate staff and resources where they are most needed, and provide data for decision making relative to infrastructure programs and resources for the system overall. And you find a link on this side to this FIX report if you have interest. Okay, go ahead and go to the next slide, please. Let me look at some of these questions. So I had a question that talks about how are policies being socialized with Native American communities? Seems there is no knowledge of primary health care. Also, how can I help as an ally? So my experience is that there has been a really a swell of interest in American Indian Alaska Native communities and education about primary health care. But a lot of the focus is on primary health care rather than public health as a whole. And the question said that there was a treaty camp in Minnesota. I would be very interested to hear more about that. There's a question related to the $5 million, a fixed amount or increased with inflation budget. I'm not really sure which cooperative agreement or grant that's referring to. Could you describe some of the reasons for spotty uptake? So it is difficult for many tribal nations to be able to have the infrastructure to be able to apply for cooperative agreements and grants and then be able to run them. Also, some of the funding can be a small amount with these particular grants, but it gets a tribal nation kind of into play and looking at public health and building that infrastructure. So I think we have to look at ways to support that and then supplemental funding that can add on to the work that's being done to develop the public health infrastructure for that tribal nation. The next question is, we know there's been understandable concerns about biomonitoring within tribes and Native communities in the past. Was this project more successful? If so, do you think that was a result of being tribally led? Yes, I think any cooperative agreement or grant that starts where a tribe is and really focuses on that tribe's needs and supports that and has flexibility to be tailored to specific tribal needs is always going to be more successful. As far as to confirm public health services, are tribal public health required to submit specific tests? Yes, there are requirements by states. I'm sorry, and I apologize. You can't see what I'm reading. It says to confirm public health services are in agreement with CDC, are tribal public health required to submit specific test results as with STIs and with TB. There are some state requirements that states work with tribes in order for to be able to access that information. And let's see, and where can we find more about the racial misclassification project? Dee, if you email me, I'm at rqj0@cdc.gov. I will get you those links. So let's see, in our remaining time, I'd like to go a little bit into CDC's Tribal Advisory Committee and Tribal Consultation. Go ahead and go to the next slide. Regarding government to government relations, the CDC ATSDR Tribal Advisory Committee is a key component upholding this relationship. The Tribal Advisory Committee advises CDC ATSDR on policy issues and broad strategies that may significantly affect American Indian Alaska Native communities. The TAC assists CDC ATSDR in fulfilling its mission to promote health and quality of life by preventing and controlling disease, injury, and disability through established and ongoing relationships and consultation sessions. Maintaining the CDC ATSDR TAC is one of OTASA's roles. The TAC is a committee made up of elected tribal leaders or their authorized representative. The TAC provides advice and recommendations to CDC ATSDR in accordance with Executive Order 13175. They meet formally twice a year through formal public health meetings to discuss American Indian Alaska Native priorities and provide feedback on important issues affecting Indian country. TAC roles include identifying evolving issues and barriers, proposing clarifications, recommendations, and solutions, serving as a forum for tribal nations, and identifying priorities and providing advice. Go ahead and go to the next slide, please. CDC ATSDR's Tribal Advisory Committee is composed of elected tribal leaders or their designated authorized representative. So its composition includes one delegate from each IHS region, and as we showed before, there's 12 of those, and 4 delegates from tribes at large. The Office of Tribal Affairs and Strategic Alliances, my office, administers the TAC, including implementing and coordinating the biannual TAC meetings. Historically, those TAC meetings have been one meeting in Atlanta and one meeting somewhere in Indian country. The designated federal official is Dr. Jose Montero, who I shared before is the director for CSTLTS. TAC functions and serves as scientific and programmatic resource. Key CDC ATSDR managers and staff, as determined by the designated federal official, serve as resources for the TAC as well. Go and go to the next slide, please. CDC ATSDR's tribal consultation policy requires that CDC and ATSDR programs consult with tribal governments when developing programs, policies, and activities that will affect American Indian and Alaska Native populations. The goals of this consultation are to assist in eliminating the health disparities faced by American Indian and Alaska Native tribes, ensuring health equity for all American Indian and Alaska Native people and communities is attained, maximizing access to critical health and human services and public health services to enhance the social, physical, and economic status of American Indian and Alaska Native tribes. Tribal consultation current status. So we have been hard at work to honor the presidential memorandum that was issued on January 26, 2021. Directing us to take a look at our tribal consultation policy and have consultation on this policy to see how we might improve it to better meet the needs of the tribal nations that we serve. So we recently held this tribal consultation on August 5th. We are on track to provide a formal response and a summary report to the testimonies provided by November 11th. Go ahead and go to the next slide, please. So as stated earlier, the CDC ATSDR TAC is made up of tribal leaders from each of the different IHS areas. While the TAC members can be used as subject matter experts to provide guidance on perspectives from each of their respective areas, they are really only able to represent their specific tribal nation. One tribe cannot speak for another, and therefore the TAC really can't act as a substitute for consultation. One tribal leader commented in a recent consultation session that the CDC ATSDR should begin engaging the TAC early in the policy and regulatory making process, so any proposed policies can be tribally informed from the start. Consultation is necessary once an action, such as policy, funding development, program services, has been identified that significantly impacts American Indian and Alaska Native populations, or even one tribal nation. It can occur across all federally recognized tribal nations or just one tribe. Who is in attendance is dependent on who the policy or issue impacts. It's also important to understand the difference between consultation and listening sessions. Consultation should occur when a formal decision needs to be made on an activity that has a large impact on tribal nations, while a listening session is to obtain informal guidance during very early stages of a project. Listening sections can also be used to get guidance on an activity or program that has lower level implications for tribal nations. Go ahead and go to the next slide, please. So moving forward, next slide. To summarize the different items we have discussed throughout this presentation, some important considerations should include direct and continuous funding sources for tribal nations to plan for resources ahead of time and have sustainable resources to build infrastructure and capacity. improve data access and quality of data to prioritize resources, flexible programs and funding opportunities to account for cultural and traditional practices that might be more effective in addressing public health prevention for American Indian and Alaska Native communities, and respect for cultural practices and community ways of knowing. When working with tribal nations and tribal partners, it is important to include tribal leaders at the beginning of planning to gather input on what might be most needed with regards to that area of public health prevention. Continuously communicating throughout the development of a project will ensure improved buy-in as well as more effective strategies to address that population's needs. Lastly, it is important not to make assumptions. Always listen, and when in doubt, ask questions. I want to end this point with a story that I experienced really early in my career related to making assumptions. I was working with a very respected tribal researcher, and she shared a story with me about a tribal nation that had reached out for assistance with trying to turn around the tide on pediatric obesity within their tribe. And the research team went to this tribal nation with some preconceptions about why this was happening, about what would be needed, and about how to move forward. And they started out in the community sharing these preconceived conceptions, and they felt like they weren't getting very far. And then one day they were at a community center, and there was some discussion, and some elders shared that this particular tribe had experienced earlier in their tribal history a very significant famine. And many people died, especially babies and smaller children. And the babies and smaller children that had survived had been the heavier kids. And this had translated into a value for heavier children, and a perceived that it was their cultural way for children to be that healthy equaled heavier or a heavier weight. As this was discussed and realized, they realized that this value had not been part of their original instructions, but had been adaptive to what had happened to them. If these researchers had not talked to the elders of the community, they would have never realized this, and they would have never been able to incorporate this knowledge into their interventions. And surely this issue was multifactorial, but this was a huge part in the piece of the puzzle that they needed to be able to work with this tribe to be able to have effective interventions. So I encourage you, as you work with tribal partners, to always have an open listening ear, to have that respect, and have that desire to not make assumptions and answer those questions. So go ahead and go to the next slide, please. These are some ways that you can connect with OTASA and CSTLTS. The tribal page, the cdc.gov/tribal, has a lot of the documents that I have referenced here. You can find our TAC charter, you can find our current CDC tribal consultation policy. You can learn more about our tribal resources. Additionally, if you want to reach out to me directly, I'll put my email in the chat box. And with that, I just go to the last slide, please. I just want to thank you very sincerely. I've been honored to be able to spend this time with you today. And I am so thankful for the work that all of you are doing. And OTASA stands ready to support as you work with tribal nations in any way.
Thank you so much, Captain Hearod. I really, really appreciate it. There are a couple of questions in the Q&A box that have added up, but I'd be interested to see, there's one person that put in a link to the racial misclassification report, and I don't know if that's
Thank
the
you.
right link or not, but I wanted to
Yeah.
get your okay before it approves. And I have a couple questions, but if you want to answer the Q&A box, go ahead.
Let me look. So as there's a question, given the unique conditions of Native Hawaiian communities, is there a mechanism TAC for supporting Native Hawaiian communities in Hawaii? Noticeably, Hawaii State is linked out in a TAC map. So Native Hawaiians have a different relationship with the United States government than the 574 federally recognized tribes. So the TAC supports that government to government relationship that we have with the 574 federally recognized tribes. I do know that CDC does do some work with Native Hawaiian communities and works to support those communities as well, but they do not have formal TAC representation because of that unique government to government relationships for federally recognized tribes. I'm wondering whether there are general resources available for CDC employees to support culturally appropriate engagement with tribal partners. Yes. So if you have interest in learning more, I would encourage you to go to the NIHB website and take the training that I discussed earlier. I can also, I'm so bad at multitasking. I used to be a police dispatcher way back in my career, and I could do it all, but I can't do it now. So maybe we can get somebody to drop that in the link. The NIHB website. I would also encourage you to visit the CDC tribal page. There's a lot of resources there. Additionally, you can always reach out to OTASA if you have any particular needs, and we would be happy to help locate that. Let's see, next I have, given the data modernization initiatives at CDC, is there a plan to do a tribal consultation for the alignment of surveillance data across centers at CDC? For example, there are often different mechanisms for tribes to share data. So we do have a data modernization work group that is addressing tribal data as well. I think as these plans kind of come together, we have suggested for some listening sessions and tribal consultation when these plans kind of align. So yes, stand by for that because I believe that those are going to be next steps coming with that. Let's see. The other question was about the data modernization initiative that I shared, how are tribal issues being addressed. If you had an opportunity in August to listen in to our tribal advisory committee, we had one section that was dedicated to data modernization issues so that we could hear from the TAC about what their experiences were. A lot came to light about data related to COVID-19 and how tribes, were able to access information and respond. And so the stars are aligning in ways I believe that we are going to have some movement forward related to DMI. Also, just as an aside, everyone from CDC is welcome to be in a listening mode on our TAC meetings. Our next TAC is going to be February 2nd and 3rd. If you visit the tribal website that I referenced earlier, you can see registration so that you can, and those meetings are very informative about a variety of issues. In August, we talked about public health infrastructure. We talked about social determinants of health. We talked about DMI and opioids. I know I'm missing something, but the TAC meetings are now being focused to be less CDC presentation and more hearing from the tribal leaders. And so I think that has made them a little bit richer as well. Let's see. Are there programs that provide funding to hire tribal members to work on public health issues within their own communities? So we have the PHELP, the Public Health Associates Program. We have really strive to identify more tribal host sites and to encourage recruitment of American Indian Alaska Native PHAPs. Additionally, the AmeriCorps public health program has just launched, which tribes are eligible for as well. I would encourage you, if you're working with tribal nations, to make them aware of these resources, because with these AmeriCorps funds, they could potentially hire tribal members or American Indian Alaska Natives to work on these public health issues in their communities. Let's see. So I believe that that is the end of the questions. Do you see any that I'm missing? Oh, okay. I want to give a shout out. I see not a question, but just want to say that I used to work with Dr. Katie Schultz, and she wanted me to let you know that she says hello. So Katie Schultz was one of the inaugural members on our Yapali Walk in 2012 with Indigenous Wellness Research, and she's a Choctaw by way of Alaska, and one of my very good friends. So please tell Dr. Schultz I said hello. So good to hear from her. I think that's the end of the questions. Are there any other questions? I think we have 5 minutes. Am I reading that right?
You're correct. Well, thank you so much for that. I mean, such a broad sweeping overview of American Indian and Alaska Native issues in the country, and as well as the past, present, and future. I very much appreciate your work, and I thought it was especially touching the personal stories you had, and how that really made it relatable to the activities that occur today in the different things that are going on. I was wondering if you could talk briefly, and I'll just probably have one final question, a little bit about jurisdictions in Indian country, and how those interact, and particularly from the public health realm, as far as county health departments, IHS, BIA, all those folks. And if you can talk briefly about that, that's a complex topic, but I think it's a topic our learners don't understand as much.
Right. And it's a very complicated topic, and it varies from state to state, tribe to tribe, county to county. Some tribal nations have established pretty good working relationships, with their county health departments or their state health departments. Others definitely do not. We hear from tribes that monies that flow through state health departments that are intended to serve American Indian Alaska Natives sometimes do not end up there or in the way that the tribal nations would request them to. We've also heard, especially with the COVID-19 vaccines, so tribes had the choice to get their vaccines through Indian Health Service or to go through the states for vaccine. Many tribes felt that they should be able to work directly government to government, with that, or that they should have the choice maybe to do both. And so that added to some complexity. Also, additionally, it's difficult because, as I shared, the majority of American Indian Alaska Natives live in urban centers, and so they might be served by a county health department. They might be served by an urban Indian organization. So how does that all work together? Additionally, as we look at data as well. Although many of the sites ask if you're American Indian or Alaska Native, I don't believe any sites are asking, are you Choctaw? Are you Cherokee? So then how do tribal nations identify, within their data, their tribal members and what services they're getting, and, how? And I had an experience in my own public health department. So I get some of my services through Choctaw Nation. I get some of my services through the county health department. And when I went for my flu shot, they didn't ask if I was American or Alaska Native. They automatically just looked at me and made an assumption and checked white. So I just say, whoa, wait a minute, check this, because I want to be represented, right? And so that goes to that misclassification as well. So additionally, so as I think public health infrastructure for tribes for most tribes is just very much at the beginning, right? Because, county states have been given money for a long time for public health infrastructure, but there hasn't really been a dedicated funding source for these activities for Indian country. And so as they become more robust, like Cherokee Nation, and they say, state of Oklahoma, we're able to take on these activities for our citizens, then what does that mean for funds that come to the state of Oklahoma? And how does that also, I think that kind of can be very complicated as well. Plus, if you have a tribe that say has 50,000 tribal members, then it might be kind of in your best interest to stand that up and have that and be able, but if you have a rancheria that say has less than 100, you know, are you going to be able to take on all those essential services? So I think the picture can be very different for many, many reasons. And so that's, I think, why, you know, there's still so much work to be left to be done, you know, for as we stand up public health infrastructure.
Certainly. Well, thank you, Captain Hearod. We're at the top of the hour. We very much appreciate your time and your efforts in this area. If you are listening, we're going to, for our audience, we're going to be back on December 1st. We'll be tentatively talking about big data and large data analysis. That's open to anybody. It's a publicly available grand rounds. Again, Captain Hearod, and we can very much appreciate, looking forward to your work in this area.
Thank you. And again,